Okay, welcome to class. We're going to go ahead and get started now. This afternoon, we're taking a look at the muscles of the human body. I sent out a list last night of all the muscles and all the actions and all the terms that we talk about today. There are only about 60 muscles altogether that we're looking at. So it's not the 206 bones plus all the processes and foramens and ridges and valleys and grooves that we have in the bones. There are going to be a few muscles that you'll need to understand their origin, their insertion, and their action. And those are very clearly identified here as we go through. So let's go ahead and get started here. Okay, there we go. Now, the muscles, their origins, their insertions, and their actions are all found listed in your lab study guide. If you go into the content section of the table of contents, in the table of contents, you will find the lab study guide for AP1 and the muscles, the 60 or so muscles are identified there. Now, we say origins and insertions and actions. So first of all, we got to understand how muscles and bones interact. Muscles pull on bones. Muscles use bones as levers to amplify their strength. Muscles aren't strong enough to do all the things we want them to do. Not strong enough for walking, talking, moving, eating, chewing, riding a bicycle, swimming, whatever. So we have to amplify their strength, and we use bones to do that. Muscles indirectly pull on bones. Muscles pull on tendons that pull on bones. And so how are they attached? Or where are they attached? Well, we look at it from, first of all, where does the muscle originate? The origin of a muscle is where it's attached to an immovable bone. You know, if it's attached to the scapula as its origin, scapula doesn't move very much. So what is the origin there? The bone that doesn't move. Its insertion is the bone that does move. For example, a muscle that is attached to the scapula as its origin will likely attach to the humerus. Now, if the origin of a muscle is the scapula, our shoulder blade, and it inserts on the head of the humerus, and the head of the humerus is the movable bone, but the bone that doesn't move is the scapula. So our origin is the scapula, the insertion is the movable bone or the head of the humerus. We see that attachment takes place at least 2 points, an origin and an insertion. You can have multiple origins. You can have multiple origins, but generally only one insertion. And our movement occurs because we are pulling the attached bone that the insertion is on. We're pulling on the bone with the insertion of the muscle. So that gives us our action, our movement. Again, bone that doesn't move, the bone that stays stationary is the muscle origin. The one that moves, for whatever reason, is the insertion. Now, here we see an example of a muscle that you'll see later on. This muscle has its insertion on the mastoid process. Mastoid process. Its origin, oops, let me get carried away with myself there. There we go. Its origin is in 2 locations. Its origin is on the clavicle and on the sternum. When this muscle, excuse me, when this muscle contracts, it pulls on the mastoid process, and that pulls the head in one direction or the other. If the left muscle contracts, it pulls the head in the left direction. If the right muscle contracts, it pulls the head in the right direction. The origin is the muscle, is the bone that moves. In this case, the mastoid process moves because the head turns. The origin is the clavicle and the sternum. They don't move. So origins and insertions. In this case, the action is to turn the head to the left or to the right. So let's take a look now. We'll start out here with the arm. So we have a model of an arm here. These are life-size models, and I can have those muscle models placed in 217. If you're in the cerebral area, if you're in the cerebral campus, I can place them in 217 in Maples Marshall Hall so that you can come in and study them just like the bones whenever it's convenient. So, very first muscle we see in the arm is right in the middle of the upper arm. It's called the Brachialis Muscle. And the Brachialis Muscle sits between two well-known muscles that we're very familiar with. It sits between the Biceps Brachii and this other muscle. The other muscle on this side is called the Triceps Brachii. The muscle that comes to a point right above the brachial is the deltoid muscle. There's our deltoid. That's where we usually get our injections. We get lots of injections in the deltoid muscle for whatever reason. And there is the Triceps Brachii. So the Biceps Brachii is the muscle on top of our arm, above the humerus. The Triceps Brachii is the muscle below the humerus. The brachial is right in between. The deltoid, our shoulder muscle, tends to cover all of this. And then down here, we have a very unique muscle. This muscle here starts on the upper arm and ends in the lower arm. It's called the Brachioradialis. And you can see it's characterized by having three nerve endings here. It extends down to the distal end of the radius. This is the muscle that lets us rotate our arm, rotate our forearm, allowing us to rotate the head of the radius around the capitulum at the end of the humerus. There's our brachioradialis. It starts on, its origin is on the humerus, its insertion is on the end of the radius, and its action is to allow to turn a doorknob, turn our keys, turn a screwdriver, screw in a light bulb. All these things that involve rotation of the radius around the capitulum, this is the muscle that allows that to happen. So let's flip the arm around now and look at it from the other perspective. There's the deltoid, large muscle of the shoulder. It covers the glenoid cavity. It covers the pectoral girdle. Its insertion is on the humerus at the deltoid tuberosity. Remember the deltoid tuberosity on the humerus? That's the insertion of the deltoid muscle. Here we have the biceps brachii on top. Here we have the triceps brachii on the bottom. These muscles, by the way, are antagonistic to each other. When the biceps contracts, the triceps relaxes. When the triceps contracts, the biceps relaxes. The teres major, just sort of throwing it in there, teres major is another muscle of the shoulder. One of the reasons I bring it out is if you have the term major, you're usually going to have the term minor. Just like inferior and superior, internal, external, things like that. So we have the teres major. You will see a teres minor here shortly. And of course, there is our brachioradialis, characterized by our three nerve endings that extend down across the muscle and how it wraps itself around the radius. So it can let you rotate your arm. And of course, there's the brachialis or brachial muscle in between the biceps and the triceps. Now, the biceps and the triceps are antagonistic. They do two very important things for us. The biceps allows us to flex our arm at the elbow. Flex means to bend. If you were to hold your arm straight out with your fingers pointed out, and then you were to bring your fingertips back and touch your shoulder, you bent your arm at the elbow to do that, and that would be flexing of the arm. So that's flexing. Now, since you can't go around like this all day, you want to get your arm back out. So now you can extend your arm, and that is when you take the fingers off your shoulder and point them straight out again. That's extending the arm. You flex at the elbow, you extend at the elbow. Now, this is accomplished by the flexing of the arm at the elbow is called flexing the elbow joint. Flexing, you shorten the angle. What's happening is the biceps brachii is pulling on the radius. The biceps brachii inserts on the radial tuberosity, and when the biceps brachii contracts, it pulls the radius backwards, shortening the angle. And so we call it flexing. Muscles can only contract. That's their only action, is they can contract. After they contract, they will relax. But all they can do is contract. And so what we do when we contract the biceps brachii, it pulls on the radial tuberosity, it pulls the radius backwards, and you end up touching your shoulder with your fingertips. The biceps, we say flexes the elbow, flexes the elbow joint. So now, what about the triceps? The triceps has sort of a aside here. The biceps has two heads. That's why we call it biceps. The triceps has three heads. We call it triceps. The triceps brachii on the underside of the arm inserts itself on the olecranon process, our elbow. So once we flexed our arm and your fingertips are up there touching your top of your shoulder, if you contract the triceps, it will pull on the elbow, on the olecranon process, and extend your arm. So flexing and extending are opposite actions. The biceps brachii causes you to flex your arm and bring your fingers up to your shoulder. The triceps causes pulls on your olecranon process and pulls your fingertips straight out again. They are antagonistic muscles. They work the opposite of each other. One flexes the arm, one extends the arm. The triceps extends the arm at the elbow. The biceps flexes the arm at the elbow. And so the insertion of the biceps is the radial tuberosity. The insertion of the triceps is the olecranon process, the elbow, if you will. And again, you can see this on this animation here. Here we see flexing. Over here, there's the radial tuberosity right there. And there's the biceps with its two heads pulling on the radial tuberosity. Here we see the triceps. You can't see its third head, but the triceps is inserted on the olecranon process here. And when the arm is flexed, pulling on the olecranon process will extend it and straighten it out. And okay, so that's the two big, those are the big antagonistic pair that we see in the arm, because muscles come in pairs. The antagonistic pairs work against each other. Now, the next big muscle, of course, is the deltoid. And the deltoid inserts on the deltoid tuberosity of the humerus. And, we say it abducts or flexes and extends the arm. So it does a lot of actions for us here. It can move the arm in a variety of directions. But the deltoid, It's the shoulder muscle, and it inserts on the deltoid tuberosity. There's the deltoid muscle. You can see there's the deltoid tuberosity right there where the blue section, our muscle is in blue, inserts right there. And we use our deltoid muscle a lot, in various actions. Plus, it's also a great shot location for, great location for injections. Now we're going to see some other muscles here. Now this muscle, haven't mentioned this one yet. This muscle right here, found at the shoulder above the spine of the scapula. That is called the supraspinatus. It is found in the supraspinous fossa, that big flat area above the spine. This is the supraspinatus. Below the spine, we have the infraspinatus. Below the spine, we have the infraspinatus, and it's found in the infraspinous fossa, in the big flat area below the spine. You're already familiar with this supraspinous fossa and the infraspinous fossa. The third muscle we see is called the Teres Minor. The Teres Minor is also found in the infraspinous fossa. Now, the Teres Minor is the counterpart to the Teres Major. This is the Teres Major right here. Now, three of these muscles belong to the rotator cuff. You've heard of the rotator cuff. Rotator cuff consists of four muscles that control the movement of the arm at the shoulder. They attach to the head of the humerus. They form a cuff around the humerus, and they enable our arm to rotate at the glenoid cavity in almost 360 degrees. We have this incredible range of motion thanks to the rotator cuff. The supraspinatus is one of the rotator cuff muscles. The infraspinatus is one of the rotator cuff muscles. The Teres Minor is one of the rotator cuff muscles. The Teres Major is just watching. It is not a rotator cuff muscle. And of course, there's the deltoid covering up a big portion of this. Rotator cuff muscles. The four muscles involved here form a cuff around the head of the humerus. They help to hold the head of the humerus snug up against the glenoid cavity, which, as we know, is not much of a cavity. It's more of a flat area. But they hold the head of the humerus tightly there, and by pulling on it in different directions, it allows the humerus to have this range of motion that is almost a complete 360 degrees in every direction. So the three muscles we saw already were the supraspinatus in the supraspinous fossa, the infraspinatus in the infraspinous fossa, and the Teres Minor also in the infraspinous fossa. The only one we didn't see is the subscapularis. The subscapularis is on the underside of the scapula in the subscapular fossa. And let's take a look at this now. Okay, so we flipped the arm over. We're looking at the posterior surface of the arm. We can see there is the subscapularis located in the subscapular fossa. And for frame of reference, there's the biceps on the top and the triceps on the bottom. Yeah. Biceps, triceps. And then here's the fourth rotator cuff muscle, the subscapularis right here. So here we see, and so now take a close look. The deltoid's gone. We're looking at the anterior perspective again, even though it's upside down. Supraspinatus, there's the spine of the scapula. Infraspinatus, below the spine of the scapula. Supraspinatus, above the spine of the scapula. This third one is the Teres Minor, right there. Those are the three rotator cuff muscles on the anterior surface of the shoulder. The subscapularis is on the other side of the scapula in the subscapular fossa. So we can't, so when we look at our rotator cuff muscles, the supraspinatus, the infraspinatus, and the teres minor. So we see them there, there, and there. And they are going to insert themselves on the head of the humerus. And then, of course, there's the subscapularis and the subscapular fossa. It inserts on the head of the humerus, as does the supraspinatus here, the infraspinatus here, and the teres minor here. And again, we see supraspinatus, infraspinatus, and teres minor. Coming in on the other side, you can't see it, but the subscapularis is going to attach itself to the head of the humerus around the corner here, if you will. So this shows you what shows three of the muscles in action. This is the head of the humerus right here. Here is the subscapular. Here's the subscapularis right here. Its insertion is on, well, its origin. The origin of all the rotator cuff muscles is on the scapula. The insertion of all the rotator cuff muscles is on the head of the humerus. Here's the subscapularis inserting on the humerus, and when it contracts, it pulls the humerus forward. When the infraspinatus and the teres minor contract, they pull the humerus, they rotate it backwards. And when the supraspinatus contracts, it raises the humerus. Because there's the supraspinatus right there. It raises the humerus up. And so the combination of all four rotator cuff muscles gives us this incredible range of motion, because we can combine the actions of all the muscles to move our arm in just about move it in any direction that we desire. So we see, again, there's the supraspinatus there, pulling on the head of the humerus. There's the infraspinatus, the teres minor, pulling on the humerus, allowing it to rotate. The infraspinatus allows our arm to rotate as we pull the humerus backwards. And of course, there's the subscapularis pulling our arm forward. Yeah. So the combination of all of these four muscles allows us an extreme flexibility at the shoulder. And it works because not only do they hold the head of the humerus in the glenoid cavity, but by holding it in tight against the glenoid cavity, it gives the arm a place to rotate on. So, and again, you can see here the infraspinatus and the teres minor are working together. All four of these work together for us. These are the rotator cuff muscles. You've heard of these. You hear about rotator cuff injuries all the time. Rotator cuff injuries tend to affect young adults and older, and then the elderly. Young adults tear their rotator cuff, damage their rotator cuff through contact sports or overuse of a particular joint. A pitcher, for example, can have a rotator cuff tear. Can tear when we say a rotator cuff tear, we're talking about tearing the tendon where a muscle, a particular one of the rotator cuff muscles, attaches to the humerus. They can become inflamed. They can become torn. So contact sports, repetitive motion injuries like that tend to affect young adults, particularly as they're playing in contact sports. Also, our older adults, our elderly adults, their rotator cuff problems come from wear and tear from life. Because we use our shoulders constantly. We use the rotator cuff muscles constantly to do things. And the wear and tear that constant activity causes is going to cause inflammation, going to tear. Now, the good news is that rotator cuff injuries are very easily repaired. Very easy repair. To repair these torn tendons, it's a pretty straightforward process to fix it. And again, why do you have elderly patients that have that surgery? It's the same reason they have knee replacement and hip replacement. It improves the quality of their life. They have the flexibility and range of motion that they didn't have before. It improves the quality of their life, and it adds years to their lifespan. So, because it shouldn't hurt to move. And if it can be fixed, we should fix it. Okay. Transitioning to the legs. So those are the muscles of the arm. The rotator cuff muscles, there are all four of them. They all have the same origin on the scapula. They all have the same insertion on the head of the humerus. And their mode of action is to rotate the humerus at the shoulder. So fairly straightforward. The other two muscles that are involved with origin and insertion and action are the biceps and the triceps. Both of them originate off the scapula and the humerus, and the biceps inserts on the radial tuberosity, and the triceps inserts in the olecranon process. One flexes the arm, and the triceps extends the arm. That's, it covers everything you need to be aware of for the arm, and plus being able to identify all the arm muscles that you saw here. Now, leg muscles. Okay. So the first one we see here in the lower leg is the tibialis anterior. Now, the tibialis anterior is important to us for a number of reasons. First of all, it's easy to find. It is adjacent to the anterior crest of the tibia, the sharp edge, the shin bone. It's on the lateral side of the anterior crest. You have that nice sharp edge there that you run into things with in the dark. The tibialis anterior is right next to that. The second thing that's important about the tibialis anterior is the tibialis anterior is used to raise our toes when we take a step. See, when we walk, our heel goes down first, and then our toes go down. Then our heel comes up, and then our toes come up. When the heels come up, the toe goes down. When the heel goes down, the toes come up. When the toes come up, the heel goes down. It's back and forth. That's, don't think about it, but that when we walk, we don't think about walking when we're doing it. At least we shouldn't be. But, heel down, heel up, toe up, back and forth. Don't try and watch your feet while you're walking. You'll run into something or you'll fall down. So anyway, I know from trying it. Tibialis anterior causes the toes of our foot, the front of our foot, to rise up. It's half of the process of walking. So the tibialis anterior pulls pulls the toes up when we take a step. Adjacent to that is the extensor digitorum longus. This muscle, along with two other sets of muscles here, cause our toes to spread out when our foot comes down. We don't pay attention to it. We might see it if we walk barefoot, but our toes will spread out to stabilize our position. And it's the extensor digitorum longus that does this, along with two other muscles. So we have the extensor digitorum longus adjacent to the tibialis anterior. Now, moving to the back of the leg, on the posterior surface, we have two muscles, one on top of the other. The closest in muscle is called the soleus muscle right there. Behind the soleus is the gastrocnemius, our calf muscle. And our calf muscle is what elevates our heel. So when we step and if our toes go up, our heel goes down. And then our toes go down and our heel goes up. So the process of walking is toes down, heel up, heel down, toes up, and so on, back and forth like that. We walk heel to toe. And it is the gastrocnemius, the calf muscle, that will raise our heel in opposition to the tibialis anterior, lowering, our toes. They're antagonistic. So that's the gastrocnemius. We have the peroneus longus and the peroneus brevis, also involved with flexing our toes out to stabilize our foot when we take a step. Okay, so these are the important muscles of the lower leg. Now, the muscle that nobody ever gets wrong on the muscle test is this one, the gluteus maximus, the butt muscle. The gluteus maximus does actually have a purpose. We'll talk about that shortly. The gluteus maximus is also not the location of injections. We don't give injections in the gluteus maximus. By the way, if you have a maximus, you're likely going to have a minimus. You may even have a medius. So, because the way anatomy terms were developed, written down hundreds of years ago, if you had a maximus, you would have a maximus. Your counterpart, that would be the minimus. So there is a gluteus minimus. There's even a gluteus medius. So it's our butt. Now we see on the side of the leg, in front of the gluteus maximus, we have a muscle called the tensor fasciae latae. It runs all the way down past the knee. Here's our extensor digitorum longus again, and our peroneus longus, our peroneus brevis, our tibialis anterior, and our soleus again, in the right perspective. So, okay, now let us, gluteus maximus. It is at the top of the leg on the posterior surface of the body. It is where we do not give injections, but you'll notice the landmark here is very important, the iliac crest. We talked about the location of the iliac crest. You can feel your iliac crest through your skin. If you locate the iliac crest and move back 2 fingers width, you will find a muscle called the gluteus medius. So in this area right in here is generally where injections are given. That's why we use the gluteus maximus as a landmark. We use the iliac crest as a landmark. We find the approximate location of the gluteus medius and injections go in there, because otherwise, if you give an injection right here in the gluteus maximus, what's directly underneath that muscle is the sciatic nerve. The sciatic nerve is hard to miss because it's about the size of our finger. And if you hit that with a syringe, with a needle on a syringe, it's going to be very, very painful for your patient. So to avoid the sciatic nerve, we give injections up here, away from that area. The gluteus medius is nowhere near the sciatic nerve. So we generally don't give injections in this area here, simply because of the risk of hitting that nerve. And that's a big nerve, and it extends all the way down behind the knee to the great toes. Now there's the tibialis anterior. I was talking about this, about what it did. The term for what the action of the tibialis anterior is dorsiflexion. Tibialis anterior allows you to flex your foot upward. Dorsiflex, raise the toes. This is dorsiflexion. We raise the toes because we have to walk heel, toe, heel, toe. It inverts the foot. It raises the foot upward. Its counterpart is plantar flexion, pointing the toe down. because we're raising the heel. And that's done by the gastrocnemius and the Achilles tendon. So this is the major role of the tibialis anterior, not because it's easy to find right next to the anterior crest, but because it dorsiflexes our foot. Okay, so let's take a look at the upper leg. We look at the thigh. We have two sets of antagonists. We have a set of an antagonistic pair in the thigh. In the front of the leg, we have the muscles known as the quadriceps or the quads. And three of them have the same first name. They're all called vastus. The vastus medialis, the vastus intermedius, which is underneath this muscle, and the vastus lateralis. Now, how do you know which is which? Well, when you look at the leg model, the big toe is always on the medial side. It's like in our bodies, our big toe is always on the medial side. You know, with our hands, we can turn our hands around so the thumbs can be out or thumbs can be in. But with our feet, we can't turn our feet around. Our big toes are always on the medial side. Our little toes are always on the lateral side. So we have the vastus medialis on the big toe side, the vastus lateralis on the little toe side. The vastus intermedius is underneath the fourth muscle, the rectus femoris. There's the vastus intermedius, intermediate right there. Vastus medialis on the medial side, vastus lateralis on the lateral side, vastus intermedius in the middle, and then the rectus femoris is the fourth of the quads. These are the four big muscles on the anterior surface of our thigh. Now, their role, and here we see the rectus femoris. This is representative of all four of them. The role of the rectus femoris is to flex the thigh at the knee and extend the lower leg. Like when you're kicking something. When you kick something, you're extending your lower leg. If you're kicking a football or a soccer ball, when you extend, the quadricep muscles allow you to extend your leg. You also can flex your leg. You can flex it at the knee and bend your leg back. So that's what the quadricep muscles allow us to do, that, to flex the thigh and extend the lower leg outward. Now, their antagonist are the hamstrings in the posterior side of the leg. These are the hamstrings. Found just below the gluteus maximus, we have three hamstring muscles that are on the posterior surface. We have what's known as the biceps femoris, the semitendinosus, and the semimembranosus. Now, how do you know which is which? Well, the semimembranosus and the semitendinosus, the tendinosus is on top of the membranosus. So first of all, you say, oh, T for top. Semitendinosus is on top of the membranosus. Now, which is medial? Well, we know that anything on the big toe side is on the medial side. A way to remember that for the semimembranosus is M for medial. So these two are on the medial side, and the biceps femoris is on the lateral side. Here they are in the model. This biceps femoris, this is the lateral side, and this is the medial side over here. Semitendinosus is on top, and the semimembranosus is underneath. These are on the medial side here. So somewhere down here is the big toe. Now, what do they do? Well, we have the biceps femoris, the semitendinosus, and the semimembranosus. What are they going to do? They are going to extend the thigh and flex the lower leg. Remember what we saw the quadricep muscles do, the quads did. The quads will allow you to extend the lower leg like you're kicking something out. You're straightening the angle out. Here, you allow the lower leg to bend. with the quadricep, with the hamstring muscles, you bend the lower leg and extend the thigh. With the hamstrings, you bend the thigh and extend the lower leg. So it can get confusing real easy. Hamstrings, the quadriceps allows you to kick. So think of it that way. They are antagonistic. When the quadriceps are contracted, the hamstrings are relaxed. When the hamstrings are relaxed, are contracted, the quadriceps are relaxed. So we go back and forth. The actions of one are the opposite action of the other. We, with the quads, we can extend our lower leg, kick our leg out. We can bend our leg back. With the hamstrings, we bend the lower leg and we extend our thigh. So antagonistic actions. Okay, along the medial side of the upper leg, on the medial side of the thigh, we have a series of muscles here, some of which are very, very distinctive. This one here is called the Sartorius muscle. This is the most unique muscle shape we encounter. This is a muscle that can be left out by itself for a lab test, and you would still know what it is, because a lot of these muscles, when you take them off the leg, a lot of them look the same. I'll just be perfectly honest here. You have to stop and think which is which. But Sartorius looks like a packing strap. It looks like shock cord, like it could have hooks on either end. It almost looks like it was painted black and rubbery and had hooks in the end. You could use it, to tie stuff down in the back of your truck. Sartorius functions like a strap. It gives us the ability to set cross-legged. It stabilizes the angle so that we can set cross-legged. There's the Sartorius. We also have the gracilis. The gracilis runs from the groin region down to the knee. On the inside of the thigh, on the medial surface of the thigh, it stabilizes the thigh. It allows you to move your thigh from side to side. Then we have two sets of muscles that run underneath the gracilis and the Sartorius. The first one is the Adductor Longus. The Adductor Longus, again, stabilizing the thigh, goes from here underneath the Sartorius. And we have the Adductor Magnus, which starts here, runs underneath the gracilis because it's there, and then runs underneath the Sartorius. These are the four muscles on the medial surface of the thigh. Gracilis right there on the medial surface of the thigh. And there's the Sartorius right there. The Sartorius is what we use when we're going to set cross-legged. You're setting cross-legged at the beach or in your chair or whatever. When we cross our legs to set on a flat surface, we crawl up into a chair or something, we use the Sartorius to do that. And again, there's your Adductor Longus right there, and the Adductor Magnus is next to it. And most of these muscles here on the medial surface of the thigh are designed to allow the thigh to move, to abduct or adduct the thigh or to stabilize it. But just be able to identify it. That's all. Now, the lower leg, characterized on the posterior surface by the calf muscle known as the gastrocnemius. The gastrocnemius has two heads, a lateral head, little toe side, and a medial head, big toe side. The heads of the gastrocnemius have their origin on the condyles of the femur. The two heads have their origin on the condyles of the femur, and they insert, the insertion of the gastrocnemius is on the calcaneus, the bone that sticks out, our heel bone, if you will, projects out past the talus. Remember, the talus is the one that has The medial malleolus and the lateral malleolus on either side of it forms the ankle structure. There is the Achilles tendon inserting on the calcaneus. This is the gastrocnemius muscles. Gastrocnemius muscle is what causes us to elevate, to raise our heel when we step. It elevates our heel. If the Achilles tendon tears, then we can't walk because we can't raise the back of our foot. So it's the calf muscle. It inserts on the calcaneus at the Achilles tendon. Its origins are from the medial and lateral condyles of the femur. Here we see it, a close-up of it. Medial head, lateral head. We don't see its origins up here, but they're right at the medial and lateral condyles. There's the soleus muscle. It has nothing to do with the gastrocnemius muscle. And there's the Achilles tendon right there. So what the gastrocnemius muscle does is allows what we call plantar flexion. You know, we point our toes down, we raise our heel. Let's say lower our heel. I meant to say raise our heel. We raise our heel with the Achilles tendon. We raise our heel and the toes go down. The Tibialis Anterior raises our toes and the heel goes down. We, with plantar flexion, the toes go down and the heel comes up. And this is what the gastrocnemius does for us. Plantar flexion. The ability to raise our heel, to lower our heel. Dorsiflexion raises our toes, our heel goes down. The tibialis anterior is doing that for us. The Achilles tendon is raising our heel, dropping our toes down. And of course, there is the calcaneus right there where the Achilles tendon attaches. Okay. And again, you see that the tibialis anterior and the gastrocnemius are antagonistic. Okay, looking at the torso, we'll start with the head. Some of these muscles are very easy to identify, and nobody ever gets them wrong on the muscle test. The first one we see is the frontalis muscle sitting on top of the frontal bone. It's a real thin muscle. Doesn't do a whole lot for us other than allow us to show expressive responses. Expression, that's what it does. Because it's not really going to be moving anything. It's just trying to contract, wrinkle our brow, you know, scrunch up our face, you know, we're happy or sad. So that's the frontalis muscle right there. Another muscle that's involved in expression is the Orbicularis Oculi. The Orbicularis, it's a circular muscle. It's a flat circular muscle. Oculi says it surrounds the eyeball. All it does is allow us to show expressive behavior, expressive responses around our eye. We have the Orbicularis oris, not involved in chewing or digestion. It's just showing expression, the oris. Here's one that does do something for us. The sternocleidomastoid. It's a mouthful of a name, but this is the muscle I showed you at the very beginning of class that allows us to turn our head left or right. Zygomaticus muscles are attached to the zygomatic bone. Again, they're more than likely used for expression, but just be able to identify them. They're in a little cluster of 3 muscles right along the right on the edge of the zygomatic bone. Now, close up of the face, the frontalis, the Orbicularis Oculi. Remember the eyeball. The Orbicularis oris right there. And you also see there's the zygomatic zygomaticus muscles right there. Now, frontalis, unlike the frontal bone, the frontalis still has is two separate muscles. It never fused together like the frontal bone did. But it's very, very thin. And when you rub your forehead, you can feel the frontal bone. So you know that the layer of muscle underneath the skin can't be very big. So there are the two circular muscles, the oris and the oculi. You know, again, primarily expression. They don't do much of anything else for us. Okay, we have a number of other muscles here. Now this is the masseter muscle. This is one of the two big chewing muscles that we see. The masseter inserts on the mandible, and it causes the mandible to elevate. We bring our lower jaw against our upper jaw, so we chew. That's what we do. That's what we're doing here when we're eating something. Because the maxilla doesn't move. The teeth in the maxilla are stationary. Hopefully the teeth in the mandible are stationary too, but the mandible brings the lower teeth against the upper teeth to crush, grind, chew, and tear. Crush, grind, rip, and tear in here. So, and this is what the masseter allows to happen. It's one of our two big chewing muscles. There's the zygomaticus muscles there. Very easy to identify. And this large muscle right here is the sternocleidomastoid. Its origins are on the sternum and the clavicle. Right here, it inserts on the mastoid process back here behind the ear. And when that muscle contracts on one side or the other, our head turns in that direction. So it's a very powerful muscle involved in rotating the head to the left or the right. And you can see right here, there's its origin. It has a head on the sternum and a head on the clavicle on each side. It inserts on the mastoid process. When one side contracts, our head turns in that direction. When the other side contracts, our head turns in the other direction. And if we contract both muscles at the same time, our head nods up and down like we're nodding yes. The head rotation. Notice how the muscle on the animation on the right-hand side, shows which side is contracting and turning our head in that direction. You can see how in the animation here, you can see how the muscle, the sternocleidomastoid on the left-hand side of the neck contracts as it rotates around. When they both contract, you get this. You get head nodding. Now, there are some extreme cases of head rotation that you don't usually see. Extremely unlikely that we would be able to rotate our head that much. But I want to keep an open mind. So, anyway, let's take a look now at those chewing muscles that I mentioned. The temporalis muscle is the other chewing muscle, the temporalis and the masseter. Now, the temporalis is right above the ear. The masseter is right in front of this big salivary gland right here. This is a salivary gland. Salivary gland's in front of the ear, and the masseter is in front of the salivary gland. The temporalis is right above the ear on the temporal bone. These are the two chewing muscles. There's the temporalis, there's the masseter. The masseter has inserts on the mandible. Its origin is on the zygomatic arch. Its action is to elevate the mandible and chew. The temporalis has its origin on the temporal bone. It also inserts on the mandible. It also elevates the mandible. And so this chewing process of bringing the mandible up again and again and again will be able to crush and grind, rip and tear. You got it right that time. The food that's in our mouth as we chew. Remember, the maxilla doesn't move. The mandible is brought up against it. And using the masseter and using the temporalis, we can accomplish that. Looks something like this. We see the mandible moving up and down thanks to the efforts of the masseter and the temporalis. The maxilla isn't moving. But whatever's that's in the mouth between the teeth is being processed. This is where digestion actually starts, is in our mouth. Large muscle on the above the shoulder, above the scapula, is called the trapezius. That's the trapezius up there. It's involved, we can elevate the scapula, extend the neck. We can turn our head to the left. We can tilt our head to the left or to the right. That's the action of the trapezius. In the front, we have a very large muscle here called the pectoralis muscle. This is called the Pectoralis Major. If you have a major, you're going to have a minor. And we'll see that the minor is tucked directly underneath the major. And while we don't think about it much, the diaphragm is also a very large muscle, shaped like a parachute. You'll see that as we're almost wrapping this up, but you'll see that shortly. So the trapezius muscle, the pectoralis major, and the diaphragm. The pectoralis major, we use this for climbing. We use it for throwing. We use it for doing push-ups. We can flex the arm. We can rotate the arm. We can do all sorts of stuff, of course. It's a very large fan-shaped muscle. It inserts on the humerus, lifting weights, push-ups, climbing up a ladder, throwing a baseball. You would use the pectoralis major. Now, when there's the pectoralis major in action, you can see its insertion is on the humerus. It's a very powerful muscle. Remember, muscle cells don't regenerate. We don't grow new muscle cells, but they can get big as we add more protein to them and we exercise them. The cells can enlarge. The trapezius, it is a large muscle, sort of a triangular, like a fan-shaped or a delta-shaped, deltoid-shaped muscle on the back. It runs up above our shoulders. It extends all the way up to the base of the skull. We can see the scapula. We can move our scapula with the trapezius muscle. We can elevate the scapula. We can shrug our shoulders. We can elevate our head. We can tilt our head over to the left or the right. There's our trapezius in action. Shrugging our shoulders, elevating our head, tilting our head backwards, tilting our head forwards, tilting it to the side. The trapezius is going to be responsible for that. So, and you can see just how large a muscle it is. And we can raise up our scapula. Now, another large muscle right below the trapezius is the Latissimus Dorsi. This is our driving a nail muscle. This is what we use to have forceful, downward action, for example. Chopping and kindling, driving a nail, that kind of action. We use it. You can also use it for pitching a softball. Fast pitch softball. The throw. The underarm throw. The underhand throw. Very powerful. Uses the Latissimus dorsi to put power behind that motion. Of course, there's the Latissimus Dorsi right there. It's a very large, very powerful muscle. Let me see what it's doing. Perhaps, perhaps in bowling. If you've ever seen anybody bowl, you know that they can have some very powerful releases. The ball practically sails down the alley. In underhand, pitching underhand in softball, you can put a great deal of power behind that. We also get a very powerful overhand action too. This is what the Latissimus Dorsi is doing for us. Now on our medial and lateral surfaces of the torso, we have the Serratus Anterior. They're there to stabilize the torso, but also the Serratus Anterior can allow us to extend our arm rapidly. Sort of like what we call the boxer's muscle. It provides this sort of punching action, if you will. So now, we also have the Pectoralis Major here, but take a look at this. Right underneath here is the Pectoralis Minor. Often we find the major and the minor side by side. Often they're running in opposite directions of the direction. The fibers of the muscle run one way on the Pectoralis Major, and on the minor they run the opposite direction. That's not uncommon. The overlap of the two directions that the muscle fibers are running provide even more strength and stability. Now the six-pack, the rectus abdominis, a series of 6 muscles that run from the xiphoid process to the inguinal region. When the rectus abdominis contracts, our abdomen flexes. Notice how it's contracting, the abdomen is flexing here. We use this when we are picking up a heavy object. We use the rectus abdominis to stabilize the abdomen. We go pick up something very heavy, a large box, moving furniture, something like that, and you reach down and pick it up, and you find this. You're not paying attention, but what's happening is your rectus abdominis muscles contract to stabilize the abdomen, so it becomes firm and rigid. What you don't notice is that you're probably holding your breath when you do that, because if you compress the abdomen, it makes it very difficult for the diaphragm to drop down. The diaphragm, which is located right here under the xiphoid process, when we take a breath, the diaphragm has to drop down to enlarge the thoracic cavity, which enlarges the lungs. The lungs are glued to the chest wall. When this muscle contracts, we tend to hold our breath. If you've ever picked up something extremely heavy and you discover that you've become a little bit dizzy or disoriented because you're picking up this very heavy object, you might even notice that your field of vision gets a little narrow. That's not unusual, because if you are compressing the abdominal cavity by contracting these muscles, you are restricting your oxygen intake. You're not breathing. You're holding your breath. And so you may become short of breath, might become a little bit dizzy. Another thing that happens is if you increase the pressure in the abdomen sufficiently, you'll stimulate a very large nerve that innervates the heart called the vagus nerve. And the vagus nerve causes the heart to slow down. The vagus nerve is used to slow down our heart rate, as opposed to the cardiac nerve, which is used to raise our heart rate. The heart doesn't have any outside controls, but it can be told to speed up or slow down. And if we stimulate the vagus nerve enough, it can slow our heart down to the point where we might pass out, or worse. It may kill your patient. It's not unusual for cardiac patients to die, or to have their heart stop. because they've been increasing their inner abdominal pressure. Now, your cardiac patients frequently are taking pain medications because of angina or because of the heart attack pain or whatever. Well, many of these pain medications that are based on morphine cause constipation. Constipation, you don't get your bowels to move, and because they probably work by their pain medication. I don't know exactly how they work. Constipation is usually caused by losing water from the feces, so maybe they do something along those lines too when they block pain. So a person that's constipated will often strain to empty their bowels. Now, straining, the term is called straining at the stool. Okay. When you strain, you raise the inner abdominal pressure to try and force feces out of your colon. That's what the same effect occurs when we pick up something heavy and we're straining to pick it up. We're contracting our rectus abdominis. We are raising the pressure inside here. So you got a cardiac patient who is straining to empty their bowels, and they strain so hard that they stimulate their vagus nerve, and it shuts down their heart rate or their heartbeat. And that may or may not kill them. They may be able to recover from that, but if they're alone and they're not around any kind of facilities, then they likely would die. So it is not unusual, to have that concern about elderly cardiac patients that are straining to empty their bowels, because you know how elderly people are. All they ever talk, all they ever talk about is when they can go to the bathroom, and empty their bowels. Well, that's not completely true, but I've known lots of older people that the highlight of the day was when they could empty their bowels. That's a whole nother story. The point is, though, that a person who is constipated is uncomfortable, and what they want to do is they want to empty their bowels. And so they strain, even though they're told not to, even though they're not supposed to. They can strain and raise the inner abdominal pressure, stimulate the vagus nerve, and stop their heart. But we use our rectus abdominis all the time. But every time we strain, every time we pick something up, we contract these muscles to stabilize our abdomen. So, now, external obliques are found on either side of the rectus abdominis, below the serratus anterior. If you stick your hands in your pocket and point the fingers towards the midline of your body, you are now in the location of the external obliques. They compress the abdomen from the side. So they're not going to flex the abdomen, they're going to compress it. And there are internal obliques directly underneath the externals, running in the opposite direction. So if the externals are angled towards the midline, right about the level of your pockets, the internal obliques are directly underneath the externals in the opposite directions, because when they crosshatch like that, they reinforce their strength. Now, other muscles, serratus anterior again. The external intercostals. These are the muscles between the ribs. These are what you eat if you eat ribs. You eat the intercostal muscles of the pig or the cow. The external intercostals, the muscle fiber direction goes towards the sternum on the external intercostals. You have an external, you got to have an internal, and the internal intercostals you're going to see are on the underside. And the fiber direction there runs away from the sternum. Of course, there's the rectus abdominis again. There are the external obliques again. Now, looking at the underside here of the abdominal cavity, we see the internal intercostals. The direction of their fibers is away from the sternum, as opposed to the externals where it goes towards the sternum. We see the internal obliques. This is all we get to see of them on our model. They're directly underneath the externals. This muscle that runs all the way across here is the transverse abdominis. Covers the whole abdominal wall. And this little edge here you see is all that we represent in this model of the diaphragm. Diaphragm is much larger, but none of this whole red and white area is the diaphragm. We just see the edge of it here. So there are the external intercostals running towards the sternum. There's the sternum right there. So we're running towards the sternum. The internal intercostals run away from the sternum. The external intercostals elevate the ribs. When we take a breath, the external intercostal muscles between the ribs contract. The rib cage rises up. At the same time, the diaphragm drops. The entire thoracic cavity enlarges. The lungs get bigger. The pressure inside the lungs drops and air rushes in. That's breathing. The internal intercostals depress the ribs. So they cause the ribs to drop down. If the diaphragm relaxes and comes up, the thoracic cavity shrinks. Air rushes out of the lungs because the lungs shrink. And we breathe out. So the internal intercostals depress the ribs. There's our diaphragm right there. See, it's shaped like a parachute. The edge of the diaphragm is right below the xiphoid process, and it covers this whole area along in here. And when we breathe, the diaphragm drops down. When it's in its relaxed position, it's shaped like a parachute, but when it contracts, it drops down and the thoracic cavity enlarges. Notice on this animation here, there's our diaphragm right there. There it's relaxing. Now it's contracting. Now it's relaxing. Now it's contracting. You notice that when the diaphragm contracts and drops, the ribs are elevated. When the ribs go up, the diaphragm goes down. When the ribs go up, the diaphragm goes down. The thoracic cavity enlarges. And that is all of our muscles. So, any questions on this? Okay, then I'm going to get us out of here, and I guess I'll see some of you in lecture tomorrow. So, okay, thanks a lot, and I'll see you later.